Hello to everyone. Thank you for your presence here at this Chilean seminar. We're going to present the challenges facing improving oral health in Chile. I want to tell you that this is a work put together by us four Chilean students here at the master's degree in dental public health. So we're going to begin. I'm going to first give a brief overview how the health system works in Chile. Chilean health system has a mixed system composed by a public and a private sector. The private sector provides health insurance for the population provided by an entity called ISAPRE, whereas the public sector provides health insurance by an entity called FONASA, and they are both regulated by the Ministry of Health. It is important to say that the public sector, FONASA, is a solidary system and works by income of the people. Around 80% of the Chilean population gets their insurance there, and the private sector, ISAPRE, is made by individual contracts, whether with individuals or with entities, and around 20% of the Chilean population provides their health in that institution. So in 2005, WHO made a commission on social determinants of health. And in this sense, the Chilean government, at that time the ex-president Ricardo Lagos, decided to adopt these strategies by acknowledging that social determinants are the major cause of health inequalities, and that poverty and health status go hand by hand. And in this sense, they decided as a government to accept that social determinants were a significant cause of health outcomes, proposed an intersectoral approach in this national health policy, emphasizing the need to embrace all key sectors of society and not just the health sector. So what has happened now is several policies have arisen. It's very slow, but we're improving things. So here we're going to divide it by an upstream, midstream, and downstream level. At an upstream level, some fiscal measurements have arisen in 2014. Major taxation have been done on soft drink, alcohol, and tobacco. And in 2013, a tobacco law was the first time it was established, mainly at banning tobacco in public areas, like workplaces and near school centers. In a midstream level, in order to support environments, there are some policies of food guidance in nurseries and schools that have been established since around 2013. One of the major strategies has been 5 a day in Chile, which is also established here in UK. And at a downstream level, most of the oral health policies and general health policies is being addressed to lower socioeconomic income. So one problem there is the fluoride varnish for preschool children, which is addressed to district of low-income families. And another program is Chile Grows With You. There is a program that started in 2007. It's a health promoting program that encourages and gives support to mothers and children, like psychological support and health support through encouraging and explaining how to engage with the health system. So we want to address now 5 major problems that we have currently now in Chile. First is the centralization of policymaking, then poor dental workforce planning, the HES program, high caries rates and high rates of untreated caries, and health service. I'm going to start with the centralization of policymaking. To understand the centralization of policymaking, we address it by four major problems, and to understand that, you have to know that the majority of health centers are established in Santiago. That means it's the capital of Chile. In this sense, and because most of the dental centers are in there, most of the dentists work in Santiago and other health professionals. That leaves that few dental specialists are in rural areas outside the capital, which are the regions. And the major problem that this creates is, for example, by people that have certain pathologies, for example, oral cancer or major maxillofacial traumas, have to be referred to the capital into a specialized dental center or medical center. What is the problem of that? Well, first, it is very expensive for the individuals, And second, because we're a very long country, it is very time consuming to go from the one edge of the country directly to Santiago. The other problem with centralization is that most of the decisions of health are taken in Santiago. Why? Because the Ministry of Health is located there. And the Ministry of Health provides health services in every region or in most regions of the country. But the problem is that these health services does not come with the local authority, first, to provide a good health needs assessment to the population, and second, they don't have the authority also to provide policies for these populations. So we have established some recommendations in order to to promote decentralization. So we are thinking that local authorities in this region must be empowerment in order to provide a good needs assessment of this population, not only in dental care, but also in medical care. And more decisions have to be made in region and not all be concentrated in the capital of Santiago.
So to continue, I will talk a little about the poor dental workforce planning that is happening in Chile. This situation is one of the main weaknesses in the dental care system, which is like this exaggerated number of dentists graduating each year. The WHO recommendation on the proportion of dentists per inhabitants on countries with similar characteristics as Chile is that one dentist should exist for 2,000 people, but this year we have one dentist for 950 people, and is expected to for the next year we're expected to have one dentist every 630 people. And also another problem is that the majority of these dentists work in the private sector, which, as Camila said, attends the 20% of the population. So the oversupply in the private, the oversupply of dentists in the private sector is massive, and in comparison with the public sector, is very imbalanced because the public sector has an undersupply of dentists. Also, there is no much regulation about accreditation of universities. So in the year 2006, the government decided to create the National Commissioning of Accreditation, but for dentistry it's not mandatory, which means that dental schools unaccredited dental schools can give and deliver legally valid diplomas, not going through a systematic evaluation, which is not good. In what's related with the curriculum of the dental schools in Chile, there is not published a document saying what is the framework. But if you look the different curriculums of universities, you can see, as happens in the majority of the countries, that the focus is on treatment and not in prevention. Also, another important point is that nowadays we don't have any regulation for immigrant dentists. So it's not very unusual to see other dentists from other parts of South America working in Chile, and the majority are in Santiago. In this graph, we can see the increase of the dental schools between the period of 1997 and 2011. So it goes, you can easily see like the big explosion of new universities in the last few years, and the majority come from the private sector. The traditional ones are like the more renowned universities, and they were founded before 1981. Nowadays we have 39 universities, which is worse than what this graph is showing. This other graph is showing the projection of the dental workforce. As we can see, it's expected, if we maintain the same circumstances that now are happening in Chile, we are expecting to have 42,500 dentists by the year 2025, which means that it's going to be a proportion of one dentist by 450 people. Well, what are our recommendations for for dealing with this situation. We think that the government should develop policies for regulating or restricting the number of dental schools and the vacancies that they are offering. In that sense, it should be necessary to implement a regulation about the accreditation of universities, to put minimal standards. Also, in the same sense, it's important to have a national examination to be able to assess the quality and evaluate the quality of the future dentists graduating from the different universities. The government can use some documents that the WHO has created for training and strengthening professionals. And also it's important to promote work in other places in the country and not just in the metropolitan region, improving the conditions of the dental workforce in those areas. These are two examples of WHO guidelines that can help the government to plan better for the health workforce. It's not just for dentistry, it's for health, and it helps to integrate like work in partnership with other sectors, not just dentistry, and to plan better. So now Camila.
Another major weaknesses of our health system is the HES program. So what is a HES program? HES program are the letters of explicit health guarantees. It's a project that was established in 2000 with a major health reform provided by ex-President Ricardo Lagos, and it was created with the objective of providing access, providing quality, and providing treatment for some high-level pathologies that were both medical and oral. So in the dental area, there are 4 explicit guarantees which address some high-risk population and high-risk prevalence pathologies. These are pregnant women, children aged 6-year-old, people aged 60-year-old, dental emergencies, and cleft lip palate pathologies. In order to understand this, I must tell you that the majority of the working hours provided by dentists in a public health center are dedicated to these HES patients because they have been established as a sanitary goal for the state of Chile. This leaves a wide range of population without attention because they are not included in this criteria of HES. So although this is a good effort to try to improve the health of the population, it is actually not a universal benefit, and what it generates is that it's a very segregated project and a segregated policy. And the current problem that right now we have in Chile is that there are major waiting lists and waiting lines of people who need to be treated that cannot get attention in the health system. So here we have a graph putting together the inequalities in access and visit to dentists by income quintile. So in the high socioeconomic groups by age, we have that they have more access to dentists and visit to the dentist, of course, whereas low socioeconomic groups, of course, they have poor access to dentists, and it's major because of this thing that I have stressed before, because they don't have the HES criteria to be attended. So we are proposing certain recommendations. For example, we want to ensure that universal health coverage is in oral health. And we also think that a proportionate universalism approach must be established according to the level of disease by age group and socioeconomic position. And one of the major things that we want to recommend is a shift, because right now the health system is mainly focused on a treatment approach, and we want to shift it to a prevention approach. Now Renato.
Well, to continue, I will briefly describe the current situation of caries in Chile. So in order to do that, we decided to plot some data available in 2 different surveys. So here we have childhood period, we can see the DMF index, and we can easily see that there is an increment during the childhood period, and children with 6-year-olds had almost a DMF index of 4. This other graph is showing Carrie's experience from childhood to adulthood, and we can clearly see that between adolescence and young adulthood, the gradient in Carrie's level is steeper. So that's important to take decisions later. We're going to discuss a little bit more about that. This table is showing social gradients. We can see different economical position in these categories, and we can see the differences between them. So people from higher socioeconomic status have better oral health outcomes than people from lower from middle, and then middle have better outcomes that lower socioeconomic status. And we can see this in all the 3 indices shown here. What are the emphasis that the current policies have now in Chile? Well, as Camila said, they mainly focus on children, and they ignore the adult population. And as we saw in the graph, caries is a disease of adulthood, so they need changes to be addressed now. And they mainly focus on treatment. And although there are some documents that talk about oral health promotion and prevention, the majority of the dentists have jobs or work in restorative activities. So in reality, that doesn't happen. And within these documents, the oral health promotion strategy or methodology used is oral health education, that we know that is not efficient in the long term, just in the short term. And the only population-based policy is the water fluoridation that reached the 80% of the Chilean territory. And although it's a controversial policy, at least it's trying to reach the entire and the whole population of Chile. What are our recommendations to improve this? Well, first of all, the decisions and strategies should be evidence-based, and the policymakers should take 2 different approaches. First, they should take an individual approach to deal with the current levels of diseases, and they need to deal with all age groups in the population and not just with children or elderly. And in order to improve oral health outcomes in the long term, population-based strategies should be developed. We need to work in partnership with other healthcare professionals or with other sectors in order to take very good policies. For example, we can use the common risk factor approach and create strategies targeting sugar intake, for example, at the schools, and restrict the intake of sugar in a better way. Or we can, for example, give subsidies to hygiene products or fluoride toothpaste to vulnerable people. And we know and we acknowledge that all this strategy need to be complemented with broader social and economical changes, political changes, in order to give the population the capacity of taking the right decisions in their lives.
The last problem we want to establish is the lack of health services that currently happens in Chile. According to WHO, in the Commission of Social Determinants, established that research is a major thing to be improved, and in this sense, there has been only 2 health services in Chile. Currently there's no a dental health survey. In the 2003 survey, there was basically most clinical data of general oral diseases like caries, periodontal disease, edentulism, and dental abnormalities, although there's a poor quality of life assessment or practically non-life quality of life assessment. And then the one done on 2009, 2010 did not provide any clinical data at all, only general questions like, for example, how many times do you go to the dentist, or what was last year, did you last year went to the dentist? And again, we have the same problem, poor quality of life assessment. This is a major issue right now because information from the health services help us, public professionals, to know the needs of the population in order to provide policies that are according to those needs. So in this matter, we are recommending that a national oral health survey should be implemented in our country, and not only to adults, also to children, and using more a socio-dental approach to assess the treatment needs. We also would like to include quality of life assessment because it's a category that in Chile is mostly not taken into account. They really like to see about prevalence of diseases, but they don't consider these issues. And include a health behavior measurements. Finally, we know we have future challenges as a country. So all of us brought together 7 major recommendations that we think Chile should improve. First of all, reduce the levels of dental caries and dental diseases, combined with oral health inequalities, must be decreased. Reorientation of public health practices towards a policy of social determinants. Health interventions must be with a population approach, which is not happening currently, which is a high-risk approach. The creation of supportive environments and strengthening community action that address social determinants of health will decrease inequalities in health and oral health. The integration of health and oral professionals into the preventive and promotional activities in non-health sectors must be accomplished. Adopting, of course, a common risk factor approach to work closely with other health professionals. Increase the resources of data collection, as we already show you that there's no, actually, right now we don't count with a proper dental health survey. And control the number of dental schools being open and the number of dentists being trained. Thank you very much.